I've been a nurse for 4 years. I started in pediatrics and I've stayed in pediatrics the entire time. And that's why I decided to incorporate teaching into, are y'all okay back there? I've decided to incorporate teaching in because we do a lot of teaching as nurses. So in my master's program, I decided to pursue nursing education. So that's just a little bit about me. That's not tested, so. I wanted to talk to you guys about the VARP testing that I had you guys take. About half of you participated in it so far, and what that is it's a test to show you how you learn. Okay. I don't know if you guys, when you took it, if you actually read what the results of your assessment were. I hope you guys did. It gives you strategies on ways to help you guys learn and comprehend better. And as you can see, there's about 4 different modalities. There's the visual learners, who learn best by watching, seeing. You have your auditory, who do better by listening and hearing somebody explain something or talking it out. You have your readers and writers, and those are the people who write down everything multiple times, and they will actually comprehend if they write it 3 or 4 times much better than the others. And then you have your kinesthetic, and those are your doers, the people who get up and actually do the task. Most of you guys came out as multimodal, which meant that you learned best using 2 different strategies or more. Those people are very lucky. What that means is you are able to take in information from multiple sources and utilize it to learn and educate yourself better and comprehend the material better, okay? The reason why I asked you guys to do that is that helps to steer how I educate you guys. For example, if you are all very strongly kinesthetic, we would be actually doing physical tasks today. I wouldn't just be lecturing or what have you. If you're very auditory, I would just be sitting here talking to you or what have you. The 3 major areas that you guys actually were very so far even across was auditory, read, write, and kinesthetic. And they were all pretty equal across the board. You're very much not visual learners apparently, which surprised me because I would assume that everybody likes to watch videos or see things done, but very much not so. So just take your time and try to incorporate some of those strategies into your learning. So for example, if you are really good with listening and auditory, try to bring in like a recorder and record your lectures for your courses. It will help you comprehend if you listen to it later, okay? So there's all that good stuff. So the 2 topics that we're basically reviewing today are the children born with developmental challenges or physical challenges. And then we're talking about care of the family of children with chronic illnesses or end of life. So the objectives that we're going to start with is we're going to be able to differentiate between what is a physical versus a developmental challenge, so you guys are aware of what those are. We're going to be able to discuss different ways on actually identifying what's a physical challenge versus a developmental challenge and how you're going to go about it in nursing, determining what those are, what they look like. We're going to also look at interventions that you can do as nurses. And then lastly, we'll look at key elements of developing a plan that you can use in the care of families of children with these situations, okay? So first things first, what is a physical challenge? Physical challenge is anything that's gonna limit a child's ability to function at what's considered a normal level as other children of comparable age. That can be anything. It can be something where they're unable to mobilize or walk like another child their age. They're limited in vision, hearing. Those are going to be deficits that they're going to have. And a lot of those are hard to identify early on because you have to do a lot of observation, and some of them you can't diagnose at infancy. Sometimes it takes a little bit older in their age to actually start seeing some of these illnesses, okay? Developmental challenges are a little bit harder. You have to look at things like reflexes. You have to, especially in infants, you have to look at their responses and how they're moving their bodies. Do they have the normal reflexes that a baby at 6 months should have? Are the reflexes that started early on in like their infancy, are those going away, or are they staying longer than they should? Okay, so that's why developmental stages are very important for you. So the key ones that we're going to look at that you see most often in Barbados are going to be children born premature. We're going to look into spina bifida and cerebral palsy. You do see some extra other ones, but they're not as common as those 3 major areas. Okay? So the first one is prematurity. Prematurity is basically any children born 3 weeks or greater earlier than they're supposed to be born. There's late preterm, which is 34 to 36 weeks. Then you have your preterm children, which are 32 to 34. Your early, which are born earlier than 32 weeks, excuse me. And your very early preterm, which are less than 25. So based on your readings and the things that you guys saw in the presentation and the lectures, what were some things that you noticed were common problems for children born preterm or premature?
They usually have cognitive deficits.
Yes, they definitely have cognitive deficits. Not all of them, but they are more prone to them, definitely. Pardon me? They do often have speech deficits. Yes, they do definitely have problems with meeting developmental milestones. Basically, if you think about any baby that's born early, they have not had fully the time to develop all of their organ systems, their development, the hormones, everything is going to be challenged. You'll notice they have global delays. You'll see things that occur with the brain, the heart, the lung, endocrine, blood, psychosocial development, learning disabilities. These children are all prone to those. It doesn't mean they're going to have them, but it means that they're more likely to have them because they were born early. Okay, and that makes sense. But that should help you better become aware of how you should associate and assess these children. When you're seeing them, you're going to want to spend a little bit more time with these children, assessing them and focusing on making sure all of their systems are within the defined ranges that you're looking for. Little things in these children can key you off onto there being a problem. For example, are they moving like a baby normally moves? Like when, are they moving both limbs equally when you're changing them? Are they crying normal? When you're doing their skin assessment, do you notice anything that looks odd on their skin? Like do they have dimples where there shouldn't be dimples on their back? Do you notice a tuft of hair at the root of their spine? Those are all indicators of something possibly going on, like spina bifida, problems with their skin or their integument, and also things like muscular dystrophy. So by watching what you're doing with your children and noticing if their behaviors are similar to what you should expect, that'll key you off that you need to either continue to watch something or perhaps determine whether or not there needs to be a medical doctor to come in and actually do a real full-on examination of what your suspicion is. Okay? Does that make sense? Okay. So with prematurity, there are a lot of different interventions that we'll go into with the development and the physically challenged children, but I'll go into that in a little bit later. I'm going to move on into the next long-term illness that you guys will commonly see. And that one's going to be spina bifida. There are 3 major types of spina bifida. Does anybody know what the 3 types are that you can think of? Okay. Well, the first and one of the most common types is called spina bifida occulta. It occurs in about 10 to 20% of the population, and it has no signs and symptoms. It just basically means there's a gap in the spine. There's no bulges of spinal fluid. There's no abnormalities in the actual vertebrae or anything like that. What you're just noticing is that there is a gap between the spinous processes. Okay. You won't see necessarily that there's any type of bladder or bowel dysfunction, no inability to move, no loss of sensation. All of it actually is normal. So it's not something that we would treat. It's something that we would be aware of. Then we have our 2 ones that we are going to want to look into treating. One is the meningocele, and the other one is the myelomeningocele. Do you guys remember what the differences are between those 2? Meningocele and myelomeningocele from your readings? Okay, so judging by your faces, no. So one of them is the meningocele is where you have the gap in the spine, which allows bulging of either spinal tissues, spinal cord, the meninges, out through the hole in the back. And depending on where it's placed on the spine is going to dictate to as to how it's going to possibly affect the child. So ones that are lower on the spine will primarily affect their bladder and their bowel and their ability to mobilize and walk. If it's higher up, it can affect other organs like their stomach. If it's up to the lower parts of the neck, they could be quadriplegic with problems with breathing, movement, all of that. Okay? But more commonly, you're just going to see it in the lower spine. With the meningosteal, the treatment initially is to make sure that the sac that it's usually encased in stays intact. The fluid that fills the sac isn't blood, it's not water, it's not saline, it's cerebral spinal fluid. And if that bursts open, the fluid that surrounds the brain and the spinal cord will come out, and it can either be a high risk for infection or you can kill your patient. Okay, so you definitely want to keep an eye on that. And they can range in size. Sometimes they're really small, but if you think of this on a baby, to us that's small. And I've seen one as large as a basketball on the back of a baby. They were obviously not born. Normally they were a C-section baby. So your intervention for those is to make sure that those stay protected, that there's no pressure put on those sacs because you don't want the sacs to rupture. You want to notify a team of any type of fluid coming out, and you want to constantly assess. You want to assess the child's movement, you want to assess their activity, and note if you see any kind of deficits or problems. Sometimes with the meningosteal, you'll see the paralysis of the lower legs or wherever, depending on how low it is. But oftentimes, you won't see symptoms from it. They just have the sac on their back, and once it's surgically resolved, the child will generally have normal function. Sometimes they'll have bladder and bowel problems where they don't have control over those, but those are less common with that kind of defect. Now, with the myelomeningocele, that one is the one that almost always has pieces or part of the your spinal nerve tract in the actual sac, along with the fluid. So these ones are almost completely noticeable that there will be dysfunction of bladder, bowel, and paralysis in usually both legs. So if you notice that you see spinal tissue or meninges actually located in it, and they're not moving their legs, that's most likely why. Same interventions, you want to keep observant, want to keep the sac safe and clean and dry and intact and the skin protected until they actually go into surgical interventions. Both of those last two options on spina bifida require surgical intervention. So of course your things is to make sure that they stay clean, free from infection, free from breakdown, and make sure the baby isn't staying on one side too much, staying on the other side, because you're not generally going to put them on their back. Does that make sense why you wouldn't put them on your back? Or on their back, excuse me? Any questions about those two topics yet? Okay. The next major area we're going to look at is cerebral palsy. And the reason why we're doing brief overviews on these is you guys have all of this stuff in your PowerPoint. You also have it in the book and the movies that we posted online for you guys to review. So I'm just touching on key areas that you guys should look at, and then we're going to go more into the nursing interventions. So with the cerebral palsy children, there are generally 4 types. The main type that we'll probably see is spastic. It accounts for 80% of their cerebral palsy children. And it's just like it sounds. They don't have complete control over their muscles, so you'll see jerky movements, repetitive movements. A lot of times they can't even uncontract, or they have no control over their body movements, and they will move in ways that you would view as abnormal, and that's baseline for them. You have dyskinetic, which is those children who also have the inability to control their movements. So while the spastic can actually voluntarily move, the dyskinetic has no control over that. Like if they're trying to move, their movements have nothing. Their brain is telling their muscles they want to do something, but the body's just doing its own thing, regardless of what you want it to. You'll also see ataxic, and these are the ones who don't have the ability to balance or coordinate their movement. So their movements might be abnormal, like one arm may be moving strange, and then the other one would be doing what they wanted to try to grab something. Okay? And then lastly, you have your mixed, and that's where you're going to see combinations of the various types of cerebral palsy. It's one of those diagnoses that you're going to see more often in younger children because they're or oftentimes it's diagnosed as a toddler because the movements don't necessarily become noticeable until they're really up and moving. There are hallmarks that you can look for, but unless you're seeing it consistently, you're not always going to assume, oh, this is a cerebral palsy or a muscular issue. So for example, a lot of babies do arching and overextension of their muscles, especially if they have like GI issues like gastric esophageal reflux. And if you see children doing that, you're automatically going to think, oh, bird, because that's what you're going to see normally. But sometimes that can be a sign that they're developing cerebral palsy. Cerebral palsy is basically, it's like a lesion or damage to the motor function center in the brain. It can either be caused in birth, it can be caused during birth by trauma to the skull or the head of the child, and it can be caused soon after birth if something happens such as high levels of in jaundice. So they can get carnivorous and it can lead to it. Or if they have like high temperatures or infections that include the cerebral spinal fluid or incorporate into the neurological system. Okay. Since spastic's the one that you're most often going to see, the interventions that we'll talk are going to be more specific to that, such as like the medical treatment, which would be like baclofen. Baclofen's a sorry. Baclofen is a medication that causes the muscles and through the central nervous system to relax more. It's a common treatment in most cerebral palsy cases or any cases where children have spasticity in their muscles. So it might be something that you'll give orally, or it might be something that's embedded directly into the child's body as a medication delivery device. And it's something that we will often use to help these children gain some increased function of their body and control of their body. The other treatments are going to include things like assessment of mobility, skin, activity. Ooh, great. Okay. So when it comes to your nursing interventions, thinking about these type of physical and developmental delays, what are some areas that you would assume that you might want to look into doing as nurses? Like what areas do you think you might want to really work on with these families and children? Support, definitely. Especially with a new diagnosis, is a good idea because what is the family going to experience when this diagnosis is given to them? Or when their baby is born and it's not doing everything they were hoping it was going to be? Kevin? Speak up. Exactly. That's exactly it. So the family will often be depressed and will be stressed out. They'll be experiencing the process of grief. Why would they be going through the process of grief? What did they lose? Their perfect child. Good job. And that's true. So your goal as a nurse is, in the social aspect of that and the psychological aspect, is to support them through this process. Because what you're seeing is that loss of that perfect child, the dreams that they had for them, and the hopes that they had for them. It doesn't mean that they can't have dreams and aspirations for these children. It just means that they might have to modify how they approach them. Okay? And that's part of your goal as a nurse, is to communicate with them openly and honestly and give them hope in situations where they have lost their hope, right? And people are going to adapt various different ways. Some families adapt really well to new diagnosis. Other families, it takes a long time for them. It just depends on what their expectations were and what they were hoping. So besides the family going through those, what about the child though? What do we want to focus with these children? We want to focus on potentiating what they can be, right? We want to make sure that they have the highest functioning that they can get to and that they can achieve. Because we want them to live as close to a normal life as they can possibly live and be able to do all the things that they want to do that they can do. We don't want to limit them by our own perception. We don't want to assume that they can or can't do anything. We want to promote that. That gives them hope for the future. That gives them emotional support. That also supports the family, gives them hope, gives them direction. and can help your family therapeutically evolve with these new diagnoses. Okay. So that's going to include things like physical therapy, occupational therapy, speech therapy, nursing therapy, medication therapy, play therapy, all those therapies. And you want to use as many of those as you can if the child needs it. Who makes those determinations though? Do you make the determination, the doctor, the family? It's everybody, correct. A lot of times we'll do what's called a care meeting with these families, and why we would do them is it incorporates the family and what they want to see happen. The doctors are going to give them honest, realistic expectation. Nursing is going to be involved to help facilitate all of that, okay? So you should be involved in those types of communications as well, okay? So remember, like, with your interventions, you want to look at ways that you can therapeutically and holistically treat these patients and their families. You want to build open lines of communication where the family feels comfortable, because oftentimes you're one of their major support systems, okay? Especially if you have parents that are newly diagnosed with something, okay? Because they're so stuck in what's going on. They don't know how they're going to cope. They don't know how their children are going to cope. The child doesn't know what they're going to cope with if they're of an age to even comprehend that there's something going on. And you are there with the knowledge and the information. So they're going to come to you, and they're going to come to you, and they're going to come to you, and they're going to ask you the same question over and over and over again. And they're going to do that because they haven't been able to process what you told them the first time. They're still processing through their grief and their loss, right? So you are their support mechanism, especially in long-term facilities and in chronic cases. You will get to know your families. You'll get to know the patients very well because oftentimes you will see them more than once a year, twice a year. You'll see them frequently because most of these children have multiple issues. So they require either surgical interventions, they require medication changes, they require new braces for their legs so that they can walk. Okay, so you'll see them a lot and you'll do a lot of education. And your relationship with them will empower them, or you will be the one who takes away their strength and their coping. So you have to be aware of new ways that you can actually look into supporting these families. If something doesn't work for them, that's fine. Figure out something else. If you talking to them doesn't work, but they want to read it, like we were talking about through your work this morning, give them stuff to read, and when they're ready to talk to you, they will. Okay? You're there to be available to them and then help them understand the condition and how to help their children be everything that they can grow into. Okay? Any questions on that so far? I know I'm throwing a lot of information really fast. Okay. So when it comes down to other nursing skills and things that you would want to do, you would want to start with like your full assessment of these patients. So I'm going to go ahead and we're going to just run through one like you were actually dealing with a baby who was diagnosed with, let's say, cerebral palsy. Okay. So first things first is you want to start with an in-depth assessment. You want to do your physical assessment of the patient. If you don't lay eyes on them and you're not looking at them and you're not touching them or listening to them, you're going to miss out on something, and then when it changes, you're not going to know. Okay, and that could impact their health outcome. Okay, so definitely start with your assessment. Your assessment should always be the number one thing. Check their vital signs. If their vital signs are normal, fantastic. How do their breaths sound? If their lungs sound like there's something going on with their breathing, and they have cerebral palsy, you might be concerned that there might be some kind of lung involvement or muscle involvement with the lungs and the breathing apparatus. Okay, all of that's going to steer your conversations with the family and the doctors, right? You're also going to do your super fun comprehensive health questionnaire, which will take you like 15 minutes. And you do definitely want to do your comprehensive health examination with these folks, okay? Because it'll often cue into things that you're not going to see because you may be just encountering this child for the first time, correct? So if you're just encountering them, how are you going to know that this is something that the family is noticing that's different? You're not unless you ask the family, okay? So the health history is very important because they will tell you, well, I just noticed that my baby has been arching a lot, but they're not corresponding to when we're feeding the baby. Oh, okay. Well, if it's not corresponding to when we're feeding, either the baby has reflux really bad, which does happen, or we need to look at something else that's going on, or that would have been something that would key us off that he has cerebral palsy or she has cerebral palsy. Why is it early that we diagnose it early? Or why is it, excuse me, not early. Why is it important that we diagnose it early?
So that we can start prevention.
Exactly. We want to start interventions and treatment as soon as possible. The earlier we diagnose something and the earlier we start treatment, the better the outcomes are in the long term for these children. Okay? Does that make sense? Okay. Also, the next thing that we're going to want to do is we're going to want to look for abnormalities. We're going to do your assessment of reflexes, especially in babies and young children. You want to look for hallmarks in development as well. So what that means is, and when it ties into reflexes, is do they still have reflexes that are past the appropriate age? So do you have a toddler who's still doing the Palmer grasp? Still. Okay. Should he be doing that? So your developmental stages are important for you to know, like your Erickson stages or your Piaget. Okay? Because you're going to look at that, and then you're going to ask the family, well, is your 6-month-old sitting up? Is he still having problems swallowing? Or do you notice that he's not sitting up, or he's arching his back and rolling it forwards? Is he having problems swallowing? Tell me what you're seeing with, or what concerns do you have as a parent? Parents often pick up on stuff way sooner than the medical personnel do because they're with those kids every day, you know? And then you're also going to want to look and see if they have any medications that they're on, any exposures to things that you would want to be concerned about, like metals, old paint, toys, or anything that can contribute to like toxicity in the blood. Because some of these signs can be because of toxic levels of metals or things in their blood system. All right. So, and then the last thing is, like we were talking about, we want to stay with the family-centered approach. We want to look at ways to incorporate the family into the care structure. Always look for ways to bring them in, because the family wants to be involved. And if you're going to send these kids home, the family needs to be involved. Otherwise, you're going to start training them on that last day that they're there, and you're going to be like, well, I hope they have all the skills necessary to give their child medicine, to feed them, and to comfort them when they're upset, because you don't know. You didn't train them until the very last day, and you didn't get to see them doing it, so you have no idea what they're going to do when they go home. And that can be overwhelming for anybody. Think about how overwhelming nursing school has been so far. Now you're going to do that to a family, but they only get like a week to do it, right? So they may not adapt as well as you guys can. So always look for ways to incorporate them. You can incorporate them with holding, teaching them how to correctly hold a baby if they are never done it. First-time parents, they are scared of holding their child. They're scared of changing diapers, especially if they were single children. You know, because they've never changed a diaper. They've seen it on TV and it looks so easy. But then when the poop comes out, they don't know what to do. It's horrible and it smells horrible, and this came out of my child and I don't know what to do. Or my child has diaper rash. What do? Their skin's gonna fall off. No, it's not. Let's just use some A&D ointment and keep their bottom clean. So approaching it with humor with them and giving them a hands-on experience will help them adapt to this, because they're getting back into the role they were expecting they were going to be able to be. They're expecting to be able to be a mom. They're expecting to be able to be a dad with this child. They're expecting to have normal interactions. Just because some of the information or some of the expectations have changed doesn't mean they no longer have those opportunities. They can still interact with these children like they were going to. And you have to be the person to empower them to do that. You're the person who's going to encourage them, who's going to give them the hand-on experience, and who's going to help them adapt to these diagnoses. Okay? Any questions? Okay. I'm going to go ahead and we're going to move on to the next section, which is care of a family of children with chronic or long-term illness and or end-of-life care. Okay? Which is nice because the information that we just went over on chronic illness will lead directly into this. The assessments and the discussion that I gave you, while most of those are still going to be valid in long-term care, they're going to be different in goals and perspective, right? Because in an acute care facility, you're looking to fix them for the short term while they're there, or to do interventions for like surgery, or if they're extra sick and they have the pneumonia or what have you, right? Or gastroenteritis, which the parents can't take care of. So in a long-term care situation, your goals are still going to be very similar. We're going to look at ways to empower the family to cope better with the diagnosis that they have. We're going to look at orienting the family to better adapt long-term to the conditions that they're experiencing. So it's going to include a couple of different things. So definitely open lines of communication are important. Honesty is important. Knowledge and your confidence in what you're doing is also going to be good. If you're scared about the diagnosis because you don't know what it is, that's going to come through, and your anxiety is going to color your responses with the family. You want to make sure that your communication, that you're not giving false hope, but you're giving realistic, hopeful goals. So if you know that a child is never going to live independently on their own, don't temporize. Don't make up that, well, it's possible. Anything's possible, but is it realistic? Okay, so keep those things in mind when you're working with families in long-term care, okay? Some of these long-term care things that you might do, you might be as a home health nurse. You could work in a long-term or a chronic care facility. And when you're there, are your goals going to be the same as they would be, or your nursing diagnoses? Are they going to be the same as they would be at like a hospital or like a polyclinic? Do you think? Why would they be different?
Trying to make the person comfortable at home, and they go live with this hospitals and polyclinics, and so usually it's a short term saying, usually saying the onset of the illness or is severe at that time, is acute illness, so you're trying to get that dealt with and get them out of the hospital.
Exactly.
There you go.
Good job, Karen. Perfect. So, yes, in an acute care facility, we're just there to get them fixed and send them home and get them back into their normal routine. That is, that's legitimately how we handle the care of those children. All right. So a couple of things to consider also, besides developing therapeutic relations and open lines of communication, is you're always going to look for ways to make sure that the patient is being optimized in their care. So is there something that we could do differently that would give them a higher quality of life? Like the children with cerebral palsy, baclofen, like we were talking about earlier, is something that can be given orally, or you can give it as a medication that is implanted into the body with a device, and it has a catheter that goes into the spine, and it releases a constant flow of medication. Yes? So the question was, would that be a risk for infection? During the surgery, yes, because you have surgical incision, right? But once it's implanted and the skin is healed, the risk for infection goes down significantly because you don't have an external barrier, and it's placed just subcutaneously. Okay? So it's not something that we're like digging deep into the body and it's invading all of these different tissues. It's not. It's just very shallow to the body. Like you can visually see the baclofen pump on a pediatric patient or any patient that's got one, and you can palpate it very easily. Okay, but some parents don't know that they can have baclofen. Sometimes they don't realize that that's a treatment that could be released constantly, or it was never discussed with them. And you, as the advocate for these families and these children, is to look for ways to increase their quality of life and their functionality. That would be something that you could recommend as an example. Other things include making sure that they're getting psychosocial development that's appropriate for them and that pushes them to be as much as they can be, right? Because they're going to grow. Some of these children are going to very well reach adulthood. They're going to go through puberty. They're going to see other people with families, and they're going to want to decide whether or not they can have their own family or if they want to have a family. And we need to empower them to have those options and those choices. Because if we don't do that and nobody tells them they can have it, they're going to think they can't have it, right? Because that's how some people think. I'm different. I don't look the same. I don't feel the same. I can't have the same thing as everybody else, and that's not necessarily true. But like I said, we want to keep it realistic. So for example, if a child with cerebral palsy has severe neurological deficits and they're unable to interact very well with their peers, we need to have realistic expectations and let family knows, oh, we're only going to reach to the 4th grade level. So you're going to need to think of long-term care. Do they need to go to a facility? Are they going to need to stay with you? Can we find them a job that they could do with a 4th grade education? Of course we can. Is it something that they're going to want to do? Probably. I don't know. We have to see what they feel like, okay? So you're going to want to incorporate those children into those decision-making processes as well, okay? So other things that we're going to do is we're going to do a lot of education. That's the big thing that you're going to always do with chronic and long-term care children. Education. Patient coping mechanisms. What is their disease? How did I get it? What do my brothers and sisters need to know about it? What do my brothers and sisters want to know? Can I catch it? It's a common question by children. Parents are going to want to know what's the outcomes. Is my child going to live with this forever? Are there medications that can make their life better? Are they going to have a family? Can they have children? So all of these things are going to be areas that you need to be aware of so that you can honestly answer and set proper expectations. Does that make sense? Okay. So the next portion of this, I set aside a little bit more time for. You're going to deal in this situation with the death of a child, okay? Because you may not have experienced death in your life, or you may have experienced a lot of death, but it's not been a child. It's very different every time. But you need to recognize how your body, how you are going to personally respond to it so that that doesn't color your interaction with the family. You may not agree with what the family's decision is during the end of life care. And if that's true, is that your choice? You can have that choice to know that. I don't agree with this. But is that your choice to put it on that family and stress them out further with your judgment? No, it's not okay. They have the right to make those decisions. Okay? So that's why it's super important for you to be aware of your responses, okay? And that does take some self-reflection. So I know nobody likes to sit there and think, oh, I have to deal with a baby dying. Or I have to deal with the next 6 months working with this child who has a terminal illness. And I have to give them the medications, I have to help the family grieve, I need to help this child understand what's going on. And I have to deal with that, because you do. You have to do all of that. Okay, and so being self-aware is going to help you not only do what you need to do as a nurse, but it's going to help you cope with the situation as well. I know plenty of nurses who have had patients pass away, and I've had patients who pass away. And every time it is a horrible experience. But what makes it tolerable is how we are able to support the family and the patient through the process. Okay? You can help them, and you can be the impact on their life that makes this from being a life-ending thing for the parents, that breaks up their marriage and their family unit, to something where they can actually deal with it, go through the stages of grief and process that pain. Okay? So that's one of the first things that you would want to do. Secondly, you want to have an open and honest communication with the parents first, and make sure you understand what their goals are in the care of their child and in their understanding of their terminal illness. Okay? If the parents don't want you to tell the patient that he's dying, you don't have the right to tell the patient that he's dying, even if you believe you do. You don't. You're not the parents. You might really, really want to, but you can't. Okay? Also, the caveat to that is a lot of times the patients, those kids, they know what's going on. They know that they're in the end of their life. They know that they're dying. And they will tell you, I'm dying, I know. Literally, I've had kids tell me. And their parents were like, don't tell them. Did you tell them? And I was like, no, they told me. I was really surprised. And that's true. And when that happens, you can actually help take that stressor away from those families by letting them know their child knows. They verbalized it to you. Because that's a stress. Can you think about how stressful it would be trying to hide a terminal illness from a child who's sick and in pain? And you knowing that as a parent and trying to keep that away from them, that pain. Please.
But if the child comes to ask you, I know really something is wrong. My mommy and daddy don't want to tell me. And they come and ask you, can you tell me what's wrong? That means that you're not really supposed to tell them, or you would inform the parents?
That's a great question, and that is correct. You would inform the parents. So what she asked was, in the situation that the child is of a mindset to ask you what's going on, what's happening, can you tell me what's going on? My parents won't tell me. You still don't have the right to tell them. Okay? It's their children. It's their children. And what if you telling them that causes major issues? okay? And stressors on that child that he didn't have them. Because they may know or they may not know. It just depends on your relationship with them and you understanding their reactions, okay? But if that child tells you that, you then want to go to the parents and be like, look, your kiddo is asking me like point blank, and I'm like, oh, you should talk to your mom and dad about that. They're going to come and ask you about it. Help the family prepare for how they want to talk to these children about it, okay? Letting them know that it is more appropriate, in your opinion, if it is, that the child have open, honest communication about what's going on with them. It's going to be more helpful than it is to be like, well, you just make the decision. I'm not. You know, your goal is to help take and remove some of that stress from their life. Right? Another thing that we're going to want to look into with these kids is we want to make sure that your treatment that you're giving is ethical and is not euthanasia. Okay? I know a lot of people are concerned about euthanasia. It's not legal here. It's somewhat legal in the United States, depending on the state that you're in. And it's one of those lines that we as nurses get very, very concerned about, because it's your license. And you guys just went through 3 years of nursing school, and now you're coming up with these situations where they're like, well, is that going to kill the kid? Well, chances are if they're on high doses of narcotics at this point, you giving them a large dose of another narcotic is probably just going to make them comfortable, okay? But what you can do if you are really concerned about the legality and the ethics of what you're doing is look at your nurse acts and what they direct you to do in those situations. If you're concerned, talk it over with either another peer or the doctor and see if they believe the dosing is okay for that patient. Which, like I said, in these situations, you're going to look at having kids who are in a lot of pain and who've been in pain for a long time, and they have probably been on morphine or Dilaudid for their whole life. And you giving a large dose of that is just making sure that they're not hurting. Okay? So it's just one of those things where you need to be aware, again, of your response, because your first response might be like, oh, I'm not giving that dose. They're crazy. I'm not going to give 6 milligrams of morphine to a 1-year-old. Because a normal 1-year-old, if you give 6 milligrams of morphine who's never had it, you're not only going to knock them out, you're probably going to stop them breathing, right? But like a kid who's had cancer, bone, osteomyelitis, who's had morphine every 2 hours for the last 2 years of their life or whatever, you give them 6 milligrams and they're just like, oh, thank you, I don't hurt anymore, okay? So that's where you have to use that thinking and that assessment process, okay? Other things to look at is we want to go ahead and make sure that you're doing a developmentally appropriate response to these children. So if the if the parents and the family give you the okay to discuss this with their child, you want to make sure you're doing things that are appropriate to their developmental stages, right? Everybody, again, favorite, Erickson and Piaget. Woo-hoo. I know you guys love it. It's everybody's favorite. But they're incredibly important, especially in end of life. Because if you tell a toddler that they're going to die, they're going to be like, okay, cool, whatever. I don't understand what that means. I'm just going to take a really long nap. That's what it is to that child in that age range. They don't have a comprehension of that. And if that's what their understanding is, you need to make sure that they understand it to the extent that they can comprehend. You're not going to try to have, a huge philosophical discussion about what death is with a toddler. It'd be a waste of your time. They're not going to get it. Same thing is just like looking at like the adolescent who's at end of life. You're going to struggle with those time frames because they're teetering between adulthood and mature thinking processes and regressing because they're now in a hospital situation. As we know, children regress when they're admitted into facilities. So you're going to see these kids waffle back and forth in their understanding. One minute they're going to be like, oh yes, I totally understand what you're saying. And the next minute they're going to be like, I have no idea what you just said. And you're like, we just talked about this 2 minutes ago. And it will happen. And you just got to roll with it and do your best to help them understand, okay? Does all of that make sense? Okay, what questions do you guys have about any of the stuff that we discussed today so far?
Battle with their child's condition. One parent said, okay, I'm not going to put my child through any suffering anymore. And the other parent is going to be like, I need to hold on, see if anything intervenes interventions can be done to improve my child's life. And both of them come to you, but how do you deal with that situation where you really and truly you're supposed to be advocating on your child's behalf, but still yet you have to deal with family members? So how do you go about dealing with that?
So this is a great question. What she asked is, you have two parents. One wants to say, I don't want to put my child through pain. I just want to let them go and let them be at peace and comfortable. The other parent is, I want to do everything possible, I want to get everything fixed, let's do whatever we can, whatever medication, if there's a trial, let's do the trial. And then you're the nurse that's caught in the middle because they both have come and talked to you. What is your role? Well, okay, that's a great question. What would you think about doing? What do you think you might do?
Talk the experiment separately first, and then come to a common ground with both of them, and then move from there, I guess.
Okay. So one suggestion is to talk with each parent separately and come to a common understanding, and then bring the family together and discuss it. What other things could we do?
To somebody here because they may need to know the legal aspects of all the decisions that they want to make. So they won't only got your point of view, they've got another professional's point of view, so they got other point of views that they can pull from other.
Okay, so the suggestion was that we bring in other professionals that will give information to them so they can make educated decisions. Well, we are the professionals too, guys. So that's a good suggestion. But other outside professionals or other specialists maybe. So if it's a cancer, maybe an oncologist or a different doctor if they want a second opinion. We can definitely recommend that. So these are definite suggestions. There's no real right answer to this question, guys. You have to feel it out. Each family is going to be very unique in how you approach them. Their own individual value system and morals are going to color how you interact with them. So you might be with one parent and be like, here's all the facts. This is what I know. This is what you got to know. The doctor told you the same thing. The other parent will be like, I need a hug. Can I just have a hug? That's all I need right now. And I will deal with the rest of this later. Because that's how they adapt to it. And you got to roll with both of them. Okay? Additionally, you want to make sure, or if you can, you want to keep those lines of communication flowing. And if they're not communicating with each other, determine why. If they're not communicating because they can't find a common ground, help them find a common ground. Okay? Help promote a way for them to have communication with each other. Because if they're not communicating, they're not connecting with their child either because they're too busy with that stress right there to necessarily focus on their child who needs them. Okay? In the video that we have on the website, which hopefully you guys will still be able to watch, if you're not able to pull it up from the website directly, try clicking into the actual link at the top of the paragraph, and it should pull you into a whole sub box, and then you might be able to cut and paste the link into your browser to view it. But definitely watch the one on the NICU from John Hopkins. It has a lot of good information on how they deal with the complications and the trauma of a death of a child. Okay? Because there's a lot of things that we can do. It's not just communication, it's not just therapeutic relationships, it's not just information, it's that human touch. You guys are people, you have emotion. You're gonna love these kids if you work in pediatrics. It's just what's gonna happen. You can't not like children, they're fun. You may not like them for a minute, but you do like them in the long run. But that's gonna color how you interact with them. Your interaction with these children is gonna be what changes their perspective and their experience with life and death, no matter how long it is. And then post-death, you're going to help the family and the siblings cope with that. You're going to assist them through the grieving process, okay? You're going to help them understand that their response is normal, whatever that is. If they're angry or if they're bargaining, if they're depressed, your goal is to bring them back up to as much normal functioning as possible post-death of their child. Helping them make memories, helping them be parents, okay? Any questions on those? Yes, please.
Have other cases dealing with, you still too have to remember to show empathy, your tone of voice. You know, sometimes you may be, something else may have you distracted, but you still need to remember to, you know, check in with your parents as much as possible. And also when they do something or say something, remember to, you know, coach them on in terms of good job or, you know, you're doing well, that kind of stuff, because they have experienced it and they need it a lot.
Absolutely. Absolutely. Yeah. So the next thing we're going to do is I'm going to have you guys get into your groups. And somebody else have a question? Please.
For instance, right, as you say, you build a therapeutic relationship with your parents. If it is that you have a child that was born with a hole in his heart, or if you have a child that was born with a hole in their heart, right, and you as a doctor say, well, your child has X amount of time to live. The child is past that, having hospitalized like 4 times since then, and you keep on preparing this person for death. How it is that you as a nurse, them trusting in you, saying, well, this is my son, you helping them prepare for death, and yet so their child ain't dying, so therefore that's like, you know what I mean? It's devastating to parents. So therefore, how it is that you still want to build a therapeutic relationship based on those sort of stuff?
No, and that's a really good question. Okay, so what she asked is basically if you have a patient who has what is considered a life-ending condition or something that's going to limit their life, and the doctors have told them your baby's going to die in 4 months, the doctor says you're going to die in 6 months, and they keep moving it because the baby keeps living past it, how are you as the nurse supposed to build these relationships with these families? That's a great question. And that happens. It absolutely does happen. And honestly, we just had stuff like this happen at the hospital that I worked at. And the family was thinking their 13-year-old kid was going to die, and he's 14 and 15 this year. So when that happens, you're going to do the best that you can to support the family. Your goal is not to be like, yes, you're going to die at 14, and I'm so sorry, let's help you do that. No, your goal is to build those therapeutic relationships and be open and honest. As we know, and normally children with these conditions don't live past this age, okay? Your kid may or may not, and we're gonna hope for the best that they live a long and happy life, and that's what we're gonna do. If something changes, then we're gonna adapt to that then, okay? So you have to be as flexible as possible with this. That means that's why you have to keep those lines of communication open and that relationship with the family that is open and honest. Because if you're saying like, as far as we can tell, it looks like your child is going to pass, we're gonna start preparing you for that. And if it doesn't happen, we're gonna celebrate with you. We're not gonna be so sad that your kid didn't die. We're gonna be super excited that your kid is continuing on in their life and that they survived whatever it was that brought them into the facility. Does that make sense? Okay, so that's part of the reason why we have to be as adaptable as possible.
Spiritual aspect is because you may have some parents that may not believe that there's a God or whatever, and then there's another parent that does believe, or both of them won't believe. But some spiritual intervention has transpired. The doctor may say you should have a certain amount of life today, but then the child lives past and they're just flourishing. And then they watch a video and they have like a pastor coming in and just maybe social worker. So you're looking at the different needs of the parent. The person is the kids have with our belief system. What I may believe and the parent may believe is 2 different conflicting things. So I might have a spiritual aspect of myself saying I believe that this child is going to live with the grace of God or whatever, and I be praying for this child, even though the family don't know I'm praying for them. But then it goes either that or negative or positive. The child might live, the child might die. But when the child dies, and they tell you that the nurse really shouldn't be praying, the parents are supposed to be the support system.
No. Crying is absolutely okay. Absolutely.
There's something that we shouldn't really be done. You shouldn't really be.
Okay, so this is part of that self-awareness thing. You knowing how you're going to respond, and I'll go into the other aspect of it, okay? Nurses cry. You're human. If you do not cry because you're detaching yourself from the situation, that's not better. That's actually worse for the family, okay? The families are often stating that when the nurse is there with them, experiencing and being honest about how they're feeling about a situation is more comforting because it gives them, like, I guess, that freedom to really grieve and to move on and to know that another human being recognized the value of the child that they had. Yeah. Pardon?
Humanistic touch.
Yes, the human touch. It matters. Humanistic. Now, when it comes to like spiritualism, that's an ethically gray area for a lot of people. If you're Christian or not, if you're atheist or not, if you're Catholic or not, you're a nurse, that's fine. Pick and choose your religion or your faith however you like. That's your personal business, okay? Now, family members may be divided on this as well. One parent might be Catholic, the other might be Muslim. or atheist or whatever. And one's going to want faith interventions, one may not. Your role is just to kind of be a facilitator in these situations and to promote communication between the parents, because you can't make that decision for them, okay? And you, like I said, if you tell them that you're praying for their children, that's fine and good because that's your faith system, as long as you're not going to cause a problem with the family, okay? Because there are families who will get very offended by that, okay? So that's going to depend on how your relation is. So you got to be careful with stuff like that, okay? But you being there and telling them that you're going to perform your nursing care to the best possible ability that you can, and make sure their child's comfortable, they're not in pain. That is what's going to matter, and that is what you're there to focus on. Okay? And making sure that their emotional and physical and spiritual well-being is also met as well. Okay. All right, great questions, guys. So I'm going to have you guys go ahead and get into your groups. We're going to look at. I know you guys have already looked at the case study with JT. What we're going to do now in class is I have the papers here for you to re-review them, and we're going to have you guys create a series of nursing diagnoses, okay? Complete diagnosis, please. So the diagnosis related to, as evidenced by, please, not just the diagnosis. I want you to prioritize them, and then what I want you guys to do is, in the group, I want you to organize what you think is the most important and why, okay? Include your assessment data, like why do I believe this nursing diagnosis is important, and then I want like a goal for each diagnosis, okay? And we'll do about 30 minutes for that, and then we'll get together and we'll review it as a group.